right. Hi, all. Thank you for coming back to Raise Nadler and Judy Converse from the Kale Kids and Chaos podcast. And today we have a very special guest, Sarah Cusick. She is a speech language pathologist with a special interest in pediatric feeding. And I know, I don't want to speak for you, Judy, but in terms of the work that you have done and I do, obviously feeding informs a lot of it. We deal with a
Yes.
lot of picky eaters and kids who are very stuck, eating the same handful of foods, and it's very difficult and frustrating for their parents. So I know in my kind of line of work, typically, if I feel that that family is really stuck and they're not able to make progress independently, I will often refer out to someone like Sarah because she has sort of this really unique niche background and understanding of feeding dynamics. So that is why we wanted to talk to you today. And I'm going to turn it over to you. So Sarah, if you don't mind, just tell us like a little bit about yourself, the name of your organization and what you do, how you do it, and then we will dive in.
Yeah. So thank you for that lovely introduction. My name is Sarah, and I own a private practice called Nourish Feeding and Speech. Um, and I also work in a variety of other settings as well on top of that. But just kind of like my background getting to this point, there's always been a common thread of food for me. And I've always been drawn to food in some way or another. So as a child, I was always kind of like experimenting with food and dreamt that I would maybe own a restaurant or something like that one day. And while I was in college, I actually looked at nutrition as a possible career path. But I didn't love all the math involved in
There's a lot of math
yeah.
and biochemistry.
Yes.
Yeah.
And so I ended up shifting and getting my culinary degree. And so I worked in fine dining for a while. And I learned so much about like the importance of the quality of ingredients and like properties that made a meal like such a special experience, like textures, flavor combinations, the chemistry actually around food. And then a really big one was like cultural importance of food and like the social experiences in those environments. It was really great. I was very passionate about that. But I needed a career that would be a little bit more flexible to a lifestyle that I was looking for. And that was difficult to do in that setting.
Food is very
So,
tough. Yeah. I
yeah,
mean, a lot of people, yeah, if you've ever like worked at a restaurant, like it's demanding, it's nights, it's weekends, it's
yeah,
holidays. Yeah, it's tough.
yeah. So unless you live there,
Right.
it's tough. And so I was kind of researching careers, and the universe pretty much just kept pushing me towards speech language pathology. And I was really like drawn towards like the feeding and swallowing disorders aspect of this field. Um, and so I just kind of advanced that common thread throughout my SLP career. Speech language pathology career, I might reference as SLP to make it a little bit shorter because it's a mouthful. But I've started deep diving into all of the complex ways that feeding and swallowing impact my clients and their day-to-day lives. So I've learned from feeding and swallowing experiences in outpatient settings, acute care in hospitals, the NICU, subacute rehab facilities where they're kind of there for like maybe, a couple weeks to 3 months. And now opening my own private practice in 2025. So it really like fills my cup and like my passion and my drive, knowing that I can help families navigate like the complexity of pediatric feeding and swallowing needs. And that's kind of like my underlying goal as a pediatric feeding therapist, is to find a way to just bring like all of that joy and happiness back to their mealtime experiences.
Right. I'm sure by the time people get to you, they're very stressed and it's
Yes.
very unpleasant often. And I guess tell us a little bit like, what do you wish more parents understood about sort of like your field and picky eating in general?
Yeah. I would say I do wish that parents kind of knew that there's just so much more to it, and it's not something that they've ever done specifically to cause their child to have a difficulty around feeding. It's always just so much more to that, and just hearing that, I think, from a provider, to know like it's not something you did, like there's underlying reasons for why this is occurring. Um, kind of takes the weight off of them.
Yeah, I imagine. And a lot of this, in my experience, I'm sure yours, Judy, is like gut issues. You know what I mean? There's a lot of,
Yeah.
biomedical stuff happening in the background that is really
Yeah.
driving a lot of this.
That's one of the big challenges, and we've talked about that, when kids are little, when they're 0 to 5, it's hard for them to express that there might be something uncomfortable. A lot of kids I worked with they didn't know any different because they had always felt uncomfortable, and eating and swallowing or digesting was always difficult, and they didn't know it wasn't normal.
Yeah.
I had one anecdote of a child on the spectrum who had a really severe, challenging, I don't want to say eating disorder because it wasn't diagnosed as such, but would actually get upset seeing his parents eat because he thought it hurt them.
Hmm.
Oh,
And
that's
because he
so,
just thought this hurts everybody.
yeah.
Yeah, so that's part of our side of it is sorting, okay, is there something organic underneath, physiological underneath? And if not, then, or even if there is, how do you proceed with a plan that's what would fall under your purview, Sarah, right? Like, how do you merge it so it all can work together?
Yeah. I think that kind of dives into like the interdisciplinary question that we were talking about later.
Yeah.
Like when do we collaborate with other specialists, and like how do we create that comprehensive plan, right? So right off the bat, when I'm doing like an initial intake or evaluation, I figure out what have we already done so far? Like who have you seen?
Yeah.
We deep dive into their med history to really get that whole picture. And sometimes that means that we have to go back and get a second opinion or a third opinion because maybe that person didn't specialize in pediatric feeding and we need someone who has a little bit more background on that. But I do like to like start that right away, seeing who we've already seen and then figuring out, okay, what step do we need to do next? Do we need to go to ENT? Do we need to go to GI? Do we need a dietitian on board? Do we think we need counseling or psych involved? Do we need an instrumental evaluation where we look at the swallow or what's happening internally from one of those specialists, including SLPs? We do X-ray swallows of or X-ray studies of the swallow, and we can also do like camera studies as well, depending on what we're thinking. So yeah, getting that interdisciplinary team set up as quickly as possible to support those families is key.
Yeah. And then how do you like, let's say you have a new patient, you're, 5, 10 minutes into your eval, like, I guess what is the typical process that you walk through or like what's going through your mind as you're doing this? Because I think for all of us, it's very similar. Like you're really sort of like trying to figure out where you need to go, right? Like you have this problem on the surface, but with your knowledge and your insight, you're like, okay, well, like here are the typical things that cause this problem, right? And so how do you start to like kind of dig through some of that and figure out where to go, what direction to take? Like what are the key things you're looking for or trying to
Yeah.
assess?
Yeah, I think initially it's kind of all over the place. And that comes with like figuring that out comes with time and experience, kind of talking to other professionals right now, like just continuing to learn from all of these different intakes and evals over time. Then you kind of figure out some more concrete roads that you would follow. But
Yeah.
first thing I'm trying to figure out is what's the family's goal? Like, what is their goal in feeding therapy? Where are they at right now? And what are they looking for? And that kind of helps drive me on like where I'm going to kind of follow the next questions.
Yeah.
For example, like if they're very medically complex and they're like on a G tube or some type of enteral feeding situation and they just want pleasure feeding and like figuring out how to do that versus just a picky eater and like the family's like, we just don't have a lot of foods right now that this kid can eat, we just want to add some foods. So figuring out what their goal is first and why they're there. And then next, kind of like I was saying before, we go through like a really thorough medical history starting from pregnancy. We want to see, like, was there anything happening with when their swallowing skills were developing? And that's in utero happening, which is crazy. But those developmental impacts can also kind of help shape like the whole picture of how the client got to the point of where they're at now, including breastfeeding, nursing, bottle feeding, what those very first feeding experiences were like. And that's really important. And then last thing I'm looking at is just current abilities. Like, without my support, without anything that I'm doing so far, like, how are the caregivers currently approaching the situation? So we kind of observe some feeding. And then I'm also looking like anatomically what's happening while they're eating. And then third factor is just kind of like that psychosocial, environmental thing that's going on. Is there stress that's happening, or do I see stress signs, or pressure that's occurring, whether or not the child or the parent or the caregiver is intending it? Just what is it looking like, and
Yeah.
getting a good idea of what the baseline is.
Got it. And then what are like the early signs as a parent, that like this is more than just a phase? Is there like a typical timeline that would be, because we all know toddlers go through jags and they have certain things that are their favorite, and then you'll buy it at Costco and all of a sudden you have like mounds of something that they're like, nope, I'm not eating that anymore, right?
Yeah.
So like everyone's experienced that. So how do you know as a parent, like, hey, this is lasting longer than it should, or my kid is in a place where like he should be expanding, in my opinion, as a parent, but he's not. Like, can you walk us through that piece? Because I feel like that's something I observe. And I'm sure, Judy, you have too, right? Especially because you've been doing this a lot longer than I have, so I'm sure you've seen over like time how, there are trends, things change, parenting
Yeah.
changes, what was normal like when I was a kid growing up is probably, only half of it's normal today,
Yeah.
So
I
like,
mean, Therese, we've talked about this. The trend toward picky eating it wasn't there in the early days of my practice, just straight up. There
yeah,
was, it wasn't part of our training. I never encountered it to the degree where it's serious enough to impact growth and development, which
yeah,
I then at the end of my tenure in clinical practice, I saw all the time. So the concern I had was, okay, we're kind of sanctioning and normalizing this in society, like saying, "Oh, it's a phase," and I'm like, no, there's stuff shifting, and there's all kinds of possibilities around how that has evolved. But yeah, basically, once a child is injuring themselves, right, because they're not growing, they're not gaining, and their developmental milestones start to lag, there's a nutrition component to that. And, there always is, even if you don't have a picky eater, there's almost always one you can find. But people don't look for those because it's not part of our general pediatrics landscape. But for kids who are, they're down to two foods and it's been a year,
right.
that
Wow.
ain't a phase.
Yeah.
There's some work you got to do. You got to do some digging and pull them out of that hole because it will affect them developmentally, especially if they're before age 4, 3, 2, whatever.
But I will say this, I do think that picky eating is somewhat normalized now. Like I think that is
Hmm.
sort of, I feel like it's rare that I meet a family where like,
Yeah.
all the kids are all good eaters, eat everything. There's always like one, that's like, oh, this is my picky eater. Um, but like, I guess that is one of those things where like, as what are like sort of, Sarah, from your perspective, like what are the red flags that parents should be looking for, right? Because I will say this, the hole gets bigger the longer it goes on, right?
Exactly.
Hmm.
So if you let this as a parent go on, because like, oh, they're a picky eater and they're difficult. And I get it. Like parents are stressed. Everyone's a dual working household. There's usually other kids and a lot of obligations and schedules and sports and like all these things, right? And as a parent, it is sometimes exhausting to come deal with picky eating at the end of the day. I get all of that. Like I live that personally. But at what point as a parent do we have to like make new parents or parents who are busy and hectic understand that like if this goes on past this point, like you need to actively make an effort to improve it. And the longer you delay doing that, the harder it is to pull your kid out of this.
Exactly. Yeah. I think like those initial red flags would be if you're noticing like if you're not, there's a guideline that I usually tell most parents is like, if you have less than 30 different foods, then you might want to look into it, right? And the biggest thing is I hear from families a lot is they're like, I just had this feeling that I needed to like look into it more. And like, everybody, the pediatrician was saying, wait and find out. And like, that was really the only person that was
You could
checking
talk to,
in.
right?
And so that's my biggest thing that I would love for parents to hear is just trust your gut. If you feel like your kid is not eating a varied diet, if you feel like your kid is pickier than your other kids or other kids within your child's social circle, it can't hurt to check in with a feeding specialist or a dietitian to just be like, hey, is my child's diet like well-rounded enough? And advocate for that second opinion. If your pediatrician is like, oh, just wait and see, and you're like, I just feel like maybe I need to talk to somebody about this, go for it. Because getting that evaluation or that initial, even just like a free consultation with someone,
Yeah.
like could open up so much more support for you and avoid getting down to 2 foods in a year, right? Like if you can
Yeah.
cut it off earlier and get just maybe your kid is just a little bit picky and we're like, you know what, I think your kid's actually doing okay. And it's just like that typical 3-year-old phase and you are doing all these great things. Here's some resources, here's some supports. If it does become more concerning, come back. And just leaving that door open for them is so
Yeah.
important.
Yeah,
Yeah.
that's so key is I love that, Sarah, that you get a little support, right? Reach out if you have an instinct that or even you just need that. It's okay to need that. It's like
It's okay for
fine, it's fine.
reassurance.
You don't have to go with your pediatrician's wait and see mantra. It's totally okay to get support and do some learning, digging, connecting for sure.
I will say on that note, access, right? So there's a lot of parents that maybe don't know that they can advocate for that or
Yeah.
that they can push back on their pediatrician's recommendation for wait and see. You can always, if your insurance, for example, requires you to get a referral from your primary care physician. If your primary care physician is refusing to give you a referral when you're asking for it, that's a flag. Go and
Yeah.
go
I
and
would
talk to
say.
a pediatrician and maybe
Yeah.
switch practices because if you're a parent that's advocating for something and your primary care physician is not supporting you when you're specifically asking for a referral and you are being blocked from services, that is not ethical. And it's okay to tell that pediatrician or medical provider, like, no, I am requesting a referral because I need this referral
Yeah.
for my own just reassurance. And that's something that you are allowed to do. Um, so access wise, that is important to know. And two, I understand that it's expensive sometimes. And so that's why a lot of feeding specialists and maybe even dietitians will have like free consults. And so if you can't get that referral or if it's taking a while to get in to your pediatrician to get those referrals, find somebody who does a free consult and get that 15 minutes of like, yes, you need to pursue this, or it kind of sounds like maybe you don't need this support, but here's some resources. That
Yeah.
is one that you could access.
This is kind of like a sidebar, but is there any like book or resource, Sarah, that you love personally that like you will share with people? I know as a dietitian, like at least in my like era of this work, it's always Ellen Satter, she's the guru, go get her book. I was curious, like, if you, as a speech language pathologist, have like a different sort of like, anything like a website, a blog, somebody that you're like, just get some information. Here's what I recommend.
Yes, I actually have a handout that I made with like small bites info, bigger
Yeah,
bites info, and then like video information,
cool.
depending on people's learning style and preference and amount of time that they have.
Yeah,
So I can share that with you guys.
cool.
But there's like social media, Instagram that has like verified dietitians, occupational therapists, speech therapists, and other like companies that are supported by evidence-based practitioners. And then there's some free courses online as well that you can like watch for some basic like pediatric feeding stuff. And then there's also a couple books that I do recommend as well on there if people are interested in just kind of learning a little bit more. So I can share that with you guys.
Yeah, I think that would be helpful, if it comes up.
Yeah.
Because I do think, verified, qualified sources is helpful. I think in the age of social media, there's a lot of people that are
Yes.
experts.
Yes.
Right.
And just kind of getting the ones that are more helpful than like direct, just kind of like, here's some ideas and like how to
Yeah.
build off of that is kind of what I look for.
Yeah, and I think our work is similar in the sense that like there is no one size fits all. And
Yeah.
this is part of the work that is required as a parent. You have to take into account your child, their personality, their preferences, and then figure out, how to adapt some of these suggestions or strategies to see if they work or if they don't, or, take a modified version.
That's what I tell a lot of my families too. I'm like, here's some resources and here's some like theories that we're using in our practice, but we have to tailor these to your child because
Yeah.
this is never going to be black and white. It's never going to be like, oh, let's do this program for 6 to 8 weeks and everything's going to be great.
Yeah.
It's all dependent on like your kid's learning style, their development, how long it takes them to feel comfortable moving forward. And so there is no timeline. There is no one size fits all
Right.
program. And that's why you need a feeding specialist or someone who specializes in the knowledge of pediatric feeding to help you navigate that. You need that interdisciplinary team with multiple providers from different lenses to support you.
Right.
And how do you like differentiate between like what could be considered today like typical picky eating, extreme picky eating, and then something like ARFID, which
Yeah.
is more of a diagnosable disorder around eating?
Exactly. So I kind of go back to looking at the whole picture. Like, how many foods does your kid consistently eat?
Mhm.
And it might not be the diet that you want them to have. It usually
Right.
isn't. But if they have a variety of textures and colors and consistencies, then I might be less concerned about like a more complex medical need that's happening, and give you just some basic kind of like picky eating tips and supports to help you kind of go off and do it on your own and not waste your time and your money coming to like therapy sessions weekly or multiple times a week, right?
Yeah.
And then that kind of middle ground picky eating where we're like, maybe we have like 10 to 20 foods and they're like varied, but it's very specific. And it's like sometimes we go on what we call like a food jag where we only eat one or two of these foods for like a really long time. And the parents are like, and then they lose it. Then they stop wanting that food. And then we switch to another one. That's
Yeah.
where I'm like, okay, let's start implementing some of these strategies and see if we can get away from that, and kind of build back up. And then the bigger red flags are like when we have failure to thrive, low weight and percentile gains, very limited foods, like less than 10 foods that are maybe all the same texture, all the same color, or all basically the same food, but in a
Different
slightly
versions, right?
form.
Different forms. Yeah.
Or if we're literally only drinking a protein shake or something, and that's the only thing that we're able to eat, then we kind of start looking a little bit deeper on what's actually going on.
Yeah. And in your experience, like, what is there like one primary driver? Is it texture? Is it temperature? Is it smell? Is it visual presentation? I'm taking taste off the table because obviously everyone's got different like propensities for what they like and don't like from a taste perspective. But is there like one or two things that have found are the primary drivers for like a majority of kids, or does it truly vary person to person?
It really truly varies person to person.
Yeah.
Everyone is so different. There are like some common themes that you hear that are just kind of like paintbrush stroke statements, which may or may not actually apply to everyone. But like one thing that I've seen or heard is like textural properties are something that some kids kind of tend to lean towards. There's a specific texture that they like, maybe because they're on the spectrum. or maybe because they have like some type of neurodiversity component that's impacting them and they really like squishy food because they like how it feels, or they like crunchy food because it's like very stimulating for them. But that still goes down to like an individual preference. So it is just very so much like, what's your favorite color? Everyone's going to have a different answer.
Sarah, one of the oft heard issues in my practice was that a child could not eat around others. The
Mhm.
sensory overload of that was
Yeah.
just beyond them, and it would cause a lot of stress and tension every evening at home at the dinner table. And parents would, be making separate meals. They'd make a meal for themselves and then for the kids and then individual meal. I'm like, you guys, we got to make this easier. But what would you say to parents experiencing that? And for those kids, it would usually be the feedback I would get is they can't stand the smell of the food. They can't stand seeing other people's mouths chewing,
Mhm.
funny things like that. And I meant bringing this up because I don't want parents to feel alone, like they're the only ones they know who's, they don't, it's an odd thing, right? So they would be nervous to share like they're, like you said earlier, like they're doing something wrong. I'm like, no, I don't think so. So what kind of approach would you take with that scenario? I'm assuming you're just going to look at the individual variation again.
Yeah, I think that ties into like how I use a neuroaffirming and trauma informed approach. So what that kind of looks like is figuring out that individual's needs. So in your example, like maybe auditory or visual stimuli is just too much for them. And that's okay. That's just like there's some people where they're like, I can't stand listening to people chewing gum. Like
Oh
it drives me
yeah.
up the wall,
I
right?
know someone who's got a thing with that.
Yeah. So like same lens. This person has like they can't handle listening to like all of these sounds while they're eating. It's overstimulating and it's ruining their meal. And so we find a way that fits that family's needs. So what does that look like? Maybe that looks like, okay, well, we'd like to all at least be on the same floor of the house during this mealtime. So maybe that person just is not ready to join in the dining room area, for example, and maybe they can sit in an adjacent room and have their own like table set up or whatever, and maybe potentially wearing headphones, like noise canceling headphones, or maybe it's far enough away where they feel comfortable not wearing headphones and that's like the amount of space that they need. You just kind of have to play with it and see what works for that person. Maybe that person wants to be in the room and so they end up just like turning their back to the table and that's enough. And then everyone else in the family just kind of educating them on like, this is okay, this is your norm, and that's fine. Maybe you guys want to go somewhere else for a meal, and that's not something that we can get to right now. But if the person who is bothered by all of these things wants to do that, then we support them. Or if they're like, no, I literally never want to eat in a restaurant, I'm good, then that's okay. You don't ever have to eat in a restaurant. That's not something you enjoy. If you don't like snowboarding, I'm not going to force you to go snowboarding. You can ski. And so figuring out using those approaches, like what a mealtime is actually going to be looking like for that person, um, and figuring out what their goal is and how we can support them.
And this, I'm sure, like one of our questions I know is getting to different age groups. So
Mhm.
that's a story for a lot of age groups at home, but then kids are going to school. How do they eat at school? And that was something I often worked with an IEP team to set up a successful lunch period for a kid because a lot of these kids would be overwhelmed with the cacophony of cafeteria and a tray line and they couldn't
Yeah.
do it and they'd absolutely flop. They'd run out of gas. They wouldn't be able to do their schoolwork. And then the teachers would be like, oh, he's inattentive. He's not focused. I'm like, no, he's starving. Okay. He
Hungry.
didn't have anything to eat since 7:30 in the morning. So that's another uh, opportunity, I guess. I would love for you to talk about that too, that parents, like we were saying earlier, can advocate for that. They don't have to just be like, oh, the school says they can't do anything. So maybe walk us through a little of that.
Yeah, and that's where we, like you were mentioning, you kind of work with the IEP team. We do have to collaborate with the professionals that are already in that space, because sometimes we can't access that space to advocate for our families. And so giving them letters of support and stating like, hey, this is what we're finding is working in our setting. Are there any ways that you could implement X, Y, and Z in your setting? Or would you be willing to have like a phone call or some type of like virtual meeting where we could brainstorm, you know, some strategies on how we can support that mealtime in that space? And what are their restrictions? Like figuring out there's always so many rules around like what they have to do. And so working with those professionals in the capacity that they're allowed to work in, to help figure out like what's the best way we could support that kid. And those cafeterias are so overstimulating.
Yeah,
Yeah.
the eternal
Even
question of when do you give kids recess versus lunch, and
right.
we're always advocating that they go outside first, run around, and
And
then
then
come
have
in and
lunch.
eat.
Because the
Yeah,
issue, as
because
you know, is like they just want to get to recess, right? So like when the lunchbox comes home half full, like, oh, what happened here? Oh, well, I just want to get to recess. You know what
yeah,
I mean? So yeah.
yeah. Plus, they get all that gross motor stuff, that vestibular and proprioceptive noise, which isn't in a good way,
Burn it
and
off. Yeah.
they can, their whole nervous system is more
Calm.
settled after all
Yeah.
that, and they can digest better and everything. But
Yep.
yeah, I'm glad to hear that. Yeah, you exactly working with those professionals in their space, and how do you transfer some successes into that space? And they are limited. I know they're overwhelmed and busy and limited, but it's still okay to ask and advocate.
Yes, exactly. And having them specifically write it into their IEP plan, because
Right.
there's also like so much turnover. Maybe like one person writes the IEP and someone else is reading it and implementing it. So making sure we're super specific on exactly what supports are needed in that feeding space.
Right.
Yeah.
Um, I'm curious too, a little bit about, if you could talk a little bit about the trauma-informed approach that you mentioned earlier, which might be a new phrase for parents around picky eating.
I feel like it's a big, scary word. We need a better word for that, because when
Okay.
I say the T word, trauma,
Right.
parents are like, are we traumatizing our child? Like,
Right.
what
So
trauma?
intense. Right.
Well, you know what, let me give you an example of one case I had of a child. Um, I cannot remember the trigger. I think there was a choking event, an actual
Yeah.
legit choking event that ended up in the
Scary.
ER.
Yeah.
And they needed, and there might have been more to that, but they needed inpatient time to go from drinking to chewing and swallowing. And this child was probably somewhere between 6 and 9 years old. This is a long time ago.
Hmm.
They had sustained them on all these specialized formulas, but they would not chew and swallow.
Hmm.
And actually, the family had to go in, and this turned into a real thing. They had to really, as you can imagine, advocate very, very hard for this.
Yeah.
But they had like a month-long, high-intensity program to address the trauma and learn to chew and swallow, and it was successful.
Yeah.
And that's kind of an extreme example of coming out of where a child's nervous system and a whole family, because the whole family gets
Hmm.
traumatized around those events, right?
Yeah.
How, getting the nervous system to shift out of that mode and into a mode where it can organize chewing, swallowing,
Hmm.
digesting.
Yeah. Um, Using that example, I kind of look at it as I love using like a bucket analogy, for a lot of like my parents to kind of understand this concept, right? So, one child in that exact situation, their bucket may have been like in this scenario really full, like they were at capacity. And that choking event was just that last drop in the bucket of maybe something else that was going on, that contributed to that, or maybe not. But whatever it was, their bucket was full, and that was the last drop that just spilled the entire bucket over and
Mhm.
created this like snowball effect of issues around feeding. Whereas another person may have had the exact same scenario happen to them, but their bucket, their like theoretical bucket, didn't have a lot of water in it. And so that extra drop was like, oh, okay, like, I could tolerate that and I can come back from it. And I'll be okay like after a day or two and go back to eating and no issues. And so we can have the exact same event happen to someone with a completely different outcome. And that's where we use that trauma informed approach. We're looking at the whole picture of, okay, like maybe to mom and dad, this was like, okay, we choked on it. We went to the ER. It was kind of a big deal, but like, we should kind of be over this a couple days later, right? Like what's happening? Or maybe you don't like that food for a while, or maybe you don't ever eat that food again because it's like scary. But like all food, like what is going on here? And so usually there's something else that was happening that built up to that point. And so that's kind of where a specialist comes in and kind of teases that apart and is like, okay, well, why was our bucket so full that event kind of ended that way? And we may never really know like the exact cause or the exact reason, but we need to know the whole picture of why was that so stressful and how can we support getting back to something that, you may never eat that food again, but how can we get back to eating and chewing and trying different foods again? And again, that goes back to using that interdisciplinary support. There's usually a psych component to it, and we usually need some counseling support in that because it was a traumatic event and we need to process that. Sometimes caregivers need to process it. And sometimes the client is like, I've already processed it. I'm good. I'm ready to move forward. But the parents are still needing the support. So, using like leaning on our team for that. It sounds like they went through a program that had a good team.
They were very lucky, and they did have to press a lot. The insurance company, of
Yeah.
course, was kind of no, 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 but they did not let go. I mean,
Yeah.
justifiably. And yeah, they did have a good outcome. So it sounds like getting back to that kernel, if you can unpeel the layers to maybe the pinpoint of the origin of it and see
Yeah.
the layers, kids can get free of that and learn these new skills.
Yeah, that's kind of like the basis of like the trauma informed approach that I use is like, well, it could be so many different things. It can be something to one person that is meaningless, and it could be the biggest thing in the world to another person.
Right.
And so just looking thoroughly through that med history from birth, it could be something like you guys were talking about earlier, a kid who thought that just swallowing was just painful all the time for everyone. And that builds up in your bucket over all those years. So that's kind of where we kind of shift and look, okay, was there trauma? What was that trauma for that person? And again, we might not know what it was specifically, but we can usually get a good idea of like, okay, this has been a pattern that's been happening, and that's probably contributing to this result.
Yeah, I mean, we've got so many great questions here if we can get to them all. But I think a good one to bring up would be the whole tethered, as you put it, Therese, tethered oral issues. You put that in your notes here.
Well,
Tongue ties.
yeah, tongue ties come up a lot. And I
Right.
don't ever think, I cannot imagine, like I was born a long time ago. I'm pretty sure it like never came up many
Right.
decades ago. So I'm curious about this particular thing. And are we really just finding more of it, or what is actually happening here?
Yeah, I think again having this what history of almost 30 years of practice, I can tell you we're finding it more. It
I
just
mean, it
goes
seems
to,
that way,
it didn't used
you
to be
know.
people weren't terribly didn't know about it. It
Yeah.
started to emerge, I would say, in terms of parents. When I say emerge, parents coming in and going, "Oh my God, I've been told there's a tongue tie with our baby, whatever." I
Yeah.
didn't start hearing that a lot until around 2003,
Mhm.
2005. And all of a sudden, it kind of snowballed from there. So, and I don't know, like, what is the current thinking? I had one very old school pediatrician who was like, don't do anything, it'll resolve. And,
Mhm.
others who were like, oh my God, you have to cut it because they'll never learn proper suck, swallow, breathe and early on. And so, yeah, I would love to hear your thoughts on that, Sarah.
Yeah, I think this is something that is very sticky right now because there's a lot of information. There's very much like a two camp like side to tethered oral tissues or tongue ties or lip ties, or now we're even starting to discuss cheek ties. And so it's just kind of a very hot topic in a lot of different fields right now. And I think there's a lot of information out there. But I think the underlying point of all of it is function, right? So is there something anatomically, anatomy wise, that is being impacted, and how is it affecting what my lens is looking at right now, which is feeding? Um, and so I take a very conservative approach to tethered oral tissues. Because I use a trauma informed, child led, um, and neurodiversity affirming approach, we don't want to include any more trauma to our mouth than we have to. And so figuring out if developmentally we can kind of work on some skills to see if we can eventually gain the function that we're looking for. And if anatomy is continuing to impact it, okay, then let's see what some other providers we could refer to, right? So we would refer to someone that specializes in tethered oral tissues. SLPs in some states can diagnose ankyloglossia, which is tongue tie or lip tie, as well. But it depends on where you're located. It depends on your background and your education. And even if you are in a state that allows that, what's your actual like background, right? And are you comfortable with diagnosing those things? So right now I rely on referring to pediatric dentists or orthodontists or ENTs who specialize in tethered oral tissues specifically. And I prefer to use providers that are also of conservative mindset, that are thinking about function. And so that's really like the foundation of all of it is function. Are we able to do all of the things that we need to do to eat and drink safely? And how is that impacting your development? Whether that's like your orofacial, like structural development, like teeth, palate. And that's where I rely on those specialists to kind of see and get their opinion of how it's impacting them. And then we make a decision as a team with the family involved and give them all of the pros, cons, and they get to decide. It's not up to us on if they're going to participate in a release or not release. That's up to them. It's our job to just inform them of, okay, this is what we're seeing and this is how it's impacting your child. And if that's important to you, this is the direction you could take. And this is the other direction you could take. And there's very few clients that I've come across where I'm like immediately off the bat, like, oh yeah, we need to go and get someone to look at this tongue tie immediately. And it is like very, very, very important that you need to do this right now. Really the only way that I would make that suggestion is if they're aspirating, which means it's like going down the wrong pipe. And into their lungs, but that doesn't always mean that a release is going to fix that. There could be other factors. So yeah, just again, looking at that whole picture before we just go releasing anatomy anywhere on our body.
Yeah. And I'm with you. I think that if the child is functioning overall, you know what I mean? That like that there, I just question sometimes when they're immediately born, but like they're breastfeeding, they're gaining weight, they're latching, they're doing all these things. And then you have someone come in and be like, oh, but they have a tongue tie or a lip tie. We should really deal with that. But it's like, but like we're doing all right. It's like, do we need to deal with that right now? You know?
Right.
And we don't want to push it. There's a fine line too, where we kind of get stuck on the fence. It's like, we don't want to push it and do the wait and see approach and be like, oh, well, they're compensating right now. We don't want compensation. We want like
Function.
adequate function,
Yeah.
for that individual. And so that's kind of where time and experience come into play, where as you kind of start looking at a variety of people in their presentation, you can kind of hone in on, okay, this is functional and it's not a compensation,
Right.
versus, okay, this is definitely they're compensating all the time and it's creating another issue.
Yeah.
And
Fair
that's
point.
where we're kind of like, okay, well, can we figure out how to stop compensating and do that first? So that's kind of the lens that I look at it from in my practice. But there's a lot of information out there, and it's very hard for parents to
Yeah.
through all of that.
That's so true. Gosh, that's very hard. It's a fire hose. It's like drinking from a fire hose. And can you give an example of, or even an anecdote of, here's how a successful feeding therapy intervention might look? How long would it take? And I know that's going to vary tremendously based on the starting point. But typical scenario, you've got, say, a child who's eating fewer than 8 foods, and obviously it's impacting them on many levels. What would be a typical timeline if there is one? Maybe there isn't one. Or how would it look like? What would it look like at the end when you're like, okay, bye. It was nice to know you. We did our thing and we're done.
Yeah,
I mean,
you've
that was always
graduated.
like, I knew I did my job when I didn't have to talk to you anymore, kind of thing.
I think I go back to that initial question at the eval. Like, what's your goal when you're coming to a feeding specialist? If your goal is to just get 30 different foods, then when we meet that goal, that's when you're done. And sometimes, especially with feeding, we develop over a period of time, right? So depending on the age of the client, if they're really young, like under the age of 1, we're maybe going to be doing like more periodic check-ins versus like consistent like weekly therapy or multiple times a week therapy, because they need time to develop that skill, versus someone who's maybe in their single digits, right? Like 3 to 9. Those approaches are going to be also on a different timeline and based on that child's development, versus like teenagers. There might be like a social factor that's happening where they're like, I don't feel comfortable eating in front of my friends because of X, Y, or Z, and I kind of want to work on that. Then that's their goal, and we'll work on that until they feel comfortable eating with their friends. So it does vary, but I kind of just go back to that initial eval and like, what's your goal? Okay, let's see how we can get there. And then we just kind of do periodic check-ins. I love breaks as well. In kind of as we're looking at the data that we're collecting in each session, they're progressing towards this goal, but maybe they've plateaued. Let's take a break for however long and come back and see if they have maintained it and gone to the next step, or if they start regressing, give me a call or an email and we'll pop back in.
Yeah.
Right. And I
And
got
then,
to throw in a question, if I can, about toddlers or young toddlers, older babies, right, who are
yeah.
in that window where they're beginning oral feeding with some solids or new
Mhm.
textures and moving off of basically liquid, breast milk or
Yeah.
formula, whatever. Can you give your opinion, totally your opinion, because I know there's tons of stuff out there. What would concern you and what would not, in terms of the window of that transition of mostly sucking and drinking
Mm-hmm.
versus chewing, rotary motion,
Yeah.
swallowing. When do you like to see, and maybe it doesn't matter, but when do you like to see kids initiate that? And if they hadn't by age, what would you be like, maybe we need to introduce that?
Yeah, that's a really good question. I again tailor it to that child's development, like
Yeah.
pattern, right? So let's say that child is, maybe chronologically a certain age, but what was their initial feeding like? Did they have NG tubes where they were being fed like not by mouth for a little while?
Mm-hmm.
Um, did they have a longer period of time with, bottle feeding or nursing or, difficulty in those stages? And is that going to push us a little bit on our expectation of when they should be developing these skills? Um, And then on top of that, was there anything else going on anatomically with them that could also impact their development? Or any like motor issues or things like that that could also be impacting their timeline of when they're developing those skills. So we look at that, and then just like kind of a basic thing that we always are looking at is oral motor skills and how long it's taking them to develop them. And we can kind of use that maybe as a pattern. We're like, okay, it took them a really long time to be able to bottle feed, for example. And so let's kind of apply that to this. We just introduced like up down mashing last month. So that's going to take a while because we've only had 30 days of exposure to trying to mash a food with our mouth. And then we shift our developmental timeline based on that. And so it is still very like individualized and tailored. And it depends on like the caregiver's cultural background too. Maybe they don't eat a lot of like certain types of foods. And so we need to be aware of, well, what are you guys eating at home? And what's your goal for like what food actually looks like for this child? There's some like cultures where a lot of the stuff is like very like mashed or pureed or like not a lot of like hard chewy textures. But they might use like bread or some type of like bread sustenance that goes with that. And so like that's what the child's like their idea of what the child should be eating. Versus us over here with like, you know, sticks of like potatoes and we're like, your kid should be chewing on a potato. And they're like, my kid's never going to chew on a potato. Like, why
We're a
would they?
beans and rice family. You know what I mean? Exactly.
Yes.
Like you don't realize. Yeah, you don't think about it.
And
So it's
so,
all everyone's very different, and that idea again of just tailoring to the specific needs of that family, that household, that child.
exactly. And then
Yeah.
tailoring it to that child's like developmental progress too, not
Hmm.
basing it on chronological age because that's almost never something that fits quite like
Yeah.
for every kid.
I really would love parents to take that into that, there's no dogma here, really. There's no like rigid dogma, and yeah, play with your intuition and look at the big picture, zoom out and look at,
Yeah.
yeah.
And I know we're at the top of the hour, but I just had one other thing, Sarah, that I wanted you to share or like get your perspective on, because I know you and I have gone a little bit back and forth on this. But the idea where many parents love to say, just try one bite.
Ugh.
Or even if the kids refuse to try one bite, they're like, I'm going to set up a reward chart. And if you do take one bite, you will get this. You know what I mean? Or if you do it 5 times, you will get a toy or whatever. So can we just talk about that if you don't mind? Because I
I,
know. I know desperation brings all sorts of like creativity. So I'm
yes.
curious about
Yes.
how your thoughts on that and like what you say.
And I think that's so important. That is a really big factor for a lot of parents. And I love educating parents on this is, do you want to have a sticker reward chart for your kid for the rest of their life while they're eating these foods? No, that's external motivation. That is not our goal. Our goal here always is to teach the child how to be independent and internally be motivated to do things. And so using those external rewards is a short-term goal and they work like temporarily, but that's not the point right now. The point is that you want your kid to be able to eventually explore foods on their own and decide what food they like and don't like and which
Be willing
foods
to
they want
try.
to
Yeah.
bring into their lives. And that's the long-term goal, is that internal intrinsic motivation that we're building that voice for them that they're going to hear inside of their head. But that's not going to come from these short-term, like quick feedback, external motivators. And so our goal is to teach that child how to be internally motivated, how to feel their hunger cues and how to listen to their body when they're too full or when they're still hungry or when that food isn't what's feeding their body, and it's making them feel different or it's making them feel not good, then let's not eat that food. That food isn't ready for you right now. And so that's the biggest thing around those external motivating factors is, okay, they're working for a short time, but I usually ask parents questions like, how long did it work for? Like maybe a couple days, maybe a couple weeks, and then we're kind of back to square one again. So that's not going to help us long term.
Right.
Yeah. Yeah. Cool. Well, Thank you for joining us. This was super
Yeah.
interesting. I mean, I will say picky eating is at the crux of a lot of what, dietitians who deal with children
Yeah.
encounter. So this was a good one.
Yeah, so many layers. I mean, there's a zillion questions, more we could ask, and definitely would love to invite families to send questions or what,
Yeah.
because this is a big topic and it does cross over with a lot of disciplines. And I think the main thing is parents don't have to go it alone. They don't have to figure it out alone. It's a lot, and yeah, it's okay.
Yeah.
Yes. And it's always okay to ask those questions and advocate for just talking to someone else about it is kind of like the underlying, I think, point. If you have if you have an issue and you're feeling it in your gut, definitely go and ask somebody else about it.
Yeah.
Find a feeding specialist, find a dietitian, find a counselor, find a GI, find an ENT, somebody that's going to listen to you, um,
Yeah.
and get you on the right path.
Agree.
Right. Well, thanks, guys.
Yes. Thank you. All right. Until next time. Thank you all for joining.